Good evening, ladies and gentlemen, and a very warm welcome to our series of inaugural lectures. I'm Anne Greenoff, and I'm head of School of Medicine, and I'm very pleased to see so many of you here this evening. King's College London awards professorships to recognise outstanding achievements in research and education. Inaugural lectures celebrate those achievements. I am delighted tonight to introduce Professor Luigi Gnudi, who is giving his inaugural lecture. Professor Gnudi obtained his MD with honours from the University of Parma in 1988. He subsequently joined the residency programme in diabetes and endocrinology at the University of Padua Medical School. He then worked as a postdoctoral fellow at the Beth Israeli Hospital, Harvard Medical School in Boston. In 1999, he obtained a PhD in endocrinological sciences from the University of Milan. In 1997, Luigi was appointed senior lecturer in the unit for metabolic medicine within the cardiovascular division at King's College London School of Medicine, and in 2011 was promoted to professor of diabetes and metabolic medicine. He has been head of the unit for metabolic medicine since 2010 and is an honorary consultant physician in diabetes, endocrinology and metabolic medicine at Guy's and St Thomas Hospital, NHS Foundation Trust. His major research interests are diabetic nephropathy and diabetic vascular complications in man. Professor Gnudi, I invite you to give your inaugural lecture entitled "Glucose is Not Always Sweet, Vascular Growth Factors in Glomerular Disease in Diabetes, all tied up." Please.
Thank you, Anne, and thank you, everybody, for coming. I would like to apologize, if you don't mind, I take this hat off, and if you are allowed to take it off, Anne. I've been informed, but I can't do that. It's very hot in here. Today I will tell you a story that started some time ago, and another bigger, longer story started even before me. I hope to entertain you. There's a little bit of raw science, and my goal is actually today to make you interested. That'll be very simple, and if my daughter who's here understands it tonight, I know I'll be a success. If it tells me I haven't got a clue what you said, then it won't be a good news. Anyway, so it all started some time ago, a long time ago, not with a castle, not with a princess, but with a bottle of urine, simple as that. I don't really want to go back to the time of the Chinese or the Greeks, so I moved the story started a little bit closer to us, otherwise it can be a little bit boring. So it's about the 12th century when Gilles de Corbet wrote a poem on judging the urine. At the time, urine were looked at, today as well, of course, and everybody was looking at color to try to understand which disease the patient had, to try to have hints of that. And this poem was a little bit of a help for a physician in a way. And the color of the urine was really important. And you see a physician there looking at the ampoules with the urine inside. And there was a little, you can see here, it didn't come very well on the slide, but a little sheet that could give you some information, red urine, brown urine, and whatever, which corresponded to some disease, to some organs. Now, this was brought also later on by Geoffrey Chaucer in the Canterbury Tale, where he describes physician on a horse or walking in the street. And the urine flask was sort of recognized like an accoutrement, I hope I pronounced this word correctly, of a stylish physician. To you, it's like having a gadget. You go around with a bottle of urine, no matter who you are. You could either be a physician or not a physician. It was like a sort of fashionable. And this sort of exploded in society. Like today, you buy a bag or something fancy, and everybody has it. And if you don't have it, you're not fashionable. That was the bottle of urine at that time. Quite interesting. Few years after, sort of a century or so, the Royal College got mad and felt pressed about these people going around in the street with a bottle of urine. And possibly a color would have been red or brown, would have been fashionable in a different way. We don't know. And so the Royal College came out with a statement. It is ridiculous and foolish to divine the course of a disease from the inspection of the urine. Kind of interesting push in a way. I guess they were really desperate. Clearly, this wasn't followed, apparently. Now, I want to bring you a little bit. About the same time, we moved from the UK to Italy. I come from Italy, so I had to put this to you. And this is a part of the frieze of a facade of the Ospedale del Ceppo in Pistoia. And we really didn't have the problem we had in the UK. Here was a fashion, but actually in Italy, urine were looked after. And here we see a physician holding the hands of the patients and assistants showing the little uroscope with the urine inside, the nurse behind, and the relatives just on the right, a little bit worried, just ready to hear what was the problem with the patients. In Italy, we had different problems, though. It was a dispute between friends who did this work. Apparently, this is from Andrea or Luca della Robbia, or of Santi Boglioni, who possibly was a student of Luca or Andrea. We don't really know. And as you know, our prime minister now is from Tuscany, and it just started this day. Hopefully, he won't have to deal with these sort of dubious questions and probably go straight into business. Let's see, we'll see in the next few years or months to come. Now, we move on, and we arrive back in the UK. And in 1827, Richard Bryce, physician here at Guy's, made a very elegant description of that where he describes an association between renal disease and protein in the urine. It was the first time. And later on, and in the 1960, Harry Keane, approximately when he was appointed as a lecturer in the Department of Medicine at Guy's, developed an interest in the association of protein in the urine and diabetes. And that was the very beginning where research really was starting with Harry at Guy's at the time. And the concept of the link between kidney and heart and cardiovascular disease, which was proposed by Richard Bright, which is still a story that we still need to really unravel and understand, this concept was getting into the research of Harry and his team. And in 1982, with Giancarlo, my mentor, who today is in Italy celebrating his 70th birthday, so happy birthday, Giancarlo, with his family, they came out with this paper. Two major concepts here. If you have protein in the urine and the protein leaks, your kidney are going to fail and the disease will progress. And the more protein you have in the urine, the more likely will be your chance of dying of cardiovascular disease. It was a major concept. And since then, and we are in the 80s, there have been many, many studies. And this made a Guy's Hospital story, which was started by Harry and Giancarlo, in which the degree of albumin in the urine was found to be correlated to, in diabetic patients, to the blood glucose level and to hypertension. And a lot of work from our group and other group, even more recently, we sort of linked in the pathogenesis of this disease the metabolic and the hemodynamic perturbations. And clearly, a lot of studies in the last 30 to 40 years telling us that if you treat patients with diabetes, if you target the glycemic control, if you target the hemodynamic control, the blood pressure with inhibitor of the renin-angiotensin system in particular, we can do much good to our patients. This was a really important work that started at Guy's and has resulted in a significant improvement of the prognosis of our patients with diabetic kidney disease. Clearly, we need to do better. And that's where sort of my story comes in. But let's set the scene for you. This is today. Today we have about 30 to 40% of patients with diabetes that will develop diabetic kidney disease. Of this 30 to 40%, a third will juggle between a tiny bit of protein in the urine, we call it microalbuminuria, and normal albuminuria. A third will stay in the microalbuminuria stage, but a third will progress towards end-stage renal disease. Now, just to give you a flavor of the big impact that the work of Harry and Giancarlo and other groups, of course, had, today, about 30 to 40% of patients, a third from microalbuminuria, will develop towards end-stage renal disease. In the 70s and the 80s, about 80% of those patients were going towards this poor endpoint. And the time from albuminuria, from microalbuminuria to end-stage renal disease, and only few reach end-stage renal disease, or the time to cardiovascular disease, because many of these patients will die before reaching dialysis. In the 80s was about 7 years, and today it's about 21 years. So great achievement, extremely important. Now, if we look at data, this is data from the US that reflects more or less what happens in the world, you see that the prevalent counts and adjusted rate for end-stage renal disease by primary diagnosis, you see diabetes is the top cause. And the line, this is up to 2008, is creeping up. Now, I just told you that we do very well. This might be secondary to diabetes epidemic, maybe. It may be due to a long life expectancy of patients. It may be due to a better way to identify patients, whatever. But diabetes still represents a huge and important cause for end-stage renal disease. When I go and visit with Sumi in a renal unit, in a dialysis unit, and we have a tour and say hello to our patients, sort of few problems here and there, half of the patients are diabetic, and we know them all. Here comes, then, as I was telling you, my work and what I want to share with you tonight. When I joined Giancarlo's group, I came from a background of intermediate metabolism, ketone bodies turnover, insulin-resistant CHAP, insulin signaling, and nothing to do with the kidney at all. And actually, I met Giancarlo, who was traveling all the time, at the interview, and then I met him about a week after, and I said, what do you want to do? And I said, well, this is my expertise. And what he told me, listen, this is a small group. We do kidney. It'd be nice if you do kidney. So since then, I joined the team. We are a little unit, a little critical mass. And then we go. So what could I do? How could I contribute? So the idea was to understand the physiology and the pathophysiology of the glomerular filtration barrier, the barrier that leaks and that causes this leakage and presence of protein in the urine that we really don't want, that really tells us the kidney is going to go bad, that is like a window on the body that's telling us that that capillary in the kidney is not functioning, so it's likely that many other little capillaries in the body is also not functioning, and that predispose this individual to a worse and bad and poor cardiovascular outcome. So we work on this data, which I want to actually show you in real. This is a mouse, sorry. I'm half a vet these days. But this is a glomerular capillaries. It's work from Catherine White, which does all our electron microscopy in Newcastle. You have a red cell passing by, and you have these nice cells on the outside of the capillary, the podocytes. Big cell body and a lot of tentacles, like an octopus. And then the endothelium in the inside is fenestrated, little holes. Pull out these, we filter our blood. We filter about 180 liters or more a day, and most of it is absorbed. If you do a section of our capillaries, you see 3 layers. You see the podocyte, the foot, the octopus on the outside, the basement membrane, and the endothelial cells inside with this glycocalyx, which is like a bush. And all these layers are very important in regulating the filtration. So we want really to understand more about this. And the goal is to find new pathways, new targetable pathways to improve the the outcome of our patients. So we set the scene. We know where we are. Now I have to introduce you to some characters that will tell you a little bit about. 3 characters. We have VEGF-A, or vascular endothelial growth factor. We have angiopoietin-1 and angiopoietin-2, 2 sisters. Now, in normal physiology, VEGF and angiopoietin-1 are constitutively expressed by the podocytes. The podocyte is the cells on the outside of the capillaries. And the receptor of these cytokines, which are secreted by the cells, are mainly on the endothelial cells. So the first question, and we've been puzzled in the last year, how on earth a cytokine expressed on the outside of the capillaries is going to work on the inside of the capillaries, especially when there is a strong filtration pressure that filters the blood, and the flow is going exactly in the opposite direction. We did some work. We also found the receptor of these cytokines on the podocyte cells. Not everybody believes that, so there's a little bit of a dispute. But there has been some interesting concept that came about in the last few years. And basically, this is about anatomy. If you imagine the vessel is like a tube, and you have the podocytes with this tentacle on the outside that go all around the tube. And then the podocyte, as a cell body, lies over these tentacles. And it forms a space, which is between the cell body, you see it on the right, and the processes that are all around the capillaries. And they form what is defined as subpodocyte space. This is work by a friend, Robert Neal in Bristol. So this subpodocyte space is like a little bit of a cave, if you want, where these growth factors do accumulate. And what do? And there is the subpodocyte space, which is fluid, it's plasma, is connected with the Bowman space, where preurine is formed, by little, I would say, holes, which are regulated by the podocytes, which is a cell that contracts and moves around. Just to make you understand a little bit better, if you want to scheme, this is an hypothesis paper, it's like a page long, published in the New England a few years ago. You have the outside of the capillaries, the endothelial cells, the basement membrane, the podocytes, and you have the accumulation of this growth factor that will move against the current in this direction, following a gradient, a concentration gradient. And this is believed that the way that this growth factor are secreted by the podocytes and act on the receptor on the endothelial cells. And more evidence is coming out now that there is this podocyte endothelial network that maintains the glomerular filtration barrier intact and able to filter properly the plasma blood. Now, I've introduced you the character. I've told you where they are and what they move, how they move. What do they do? Why are they important? VEGF is constitutively expressed by the podocytes. And VEGF is a pro-permeability factor. It makes, allows plasma to flow, to form the preurine, and is there. And it's one of the few areas in the body where this is expressed. And the angiopoietin have a different role. Angiopoietin-1, which is normally expressed in the glomerular capillaries, it has the role to keep your vessel tight, intact and happy. The moment you have an insult of any nature, blood pressure, glucose, anything, what happens is that angiopoietin-2 kicks in, is produced, is expressed. And angiopoietin-1 and angiopoietin-2 binds to the same receptor. So they compete for the same receptor. Angiopoietin-1 will activate the receptor, angiopoietin-2 will inactivate the receptor. Angiopoietin-2, when it's expressed in disease, will destabilize the vessel wall, allowing VEGF, which will be upregulated, it happens all the time, to allow new vessel formation, endothelial cell proliferation, new vessel. We see that in the eye, we see that in the kidney, and etc. So these are the characters. What happens in diabetes? In diabetes, exactly this. We have an insult, we have hyperglycemia. At the level of the glomerulus, we have hemodynamic perturbation, which will provoke an important insult, and the two insults will synergize one to each other, we have upregulation of VEGF. At the same time, we have a system which I won't go in detail. We have nitric oxide deficiency, uncoupling of VEGF. And the formation of this new vessel, which a repair, if you want, is abnormal. These vessels are not working well. We have vascular damage. We have a lot of system kicking in to try to repair the vessel because the insult is there, it's chronic, and the body is trying to repair. And this will result in a scar that goes on and on and on. And then your nice filter, the nice glomerular that filters blood, is gradually substituted by a scar. A scar cannot filter, and it's dialysis time. And this is really what happens. So abnormal vessel and scar. So VEGF is quite essential. The work we wanted to do is to understand really what is the role of VEGF. Can we know it's upregulated in diabetes. Can we do anything to, is it possible to target? Can we do something? And we'll see these slides a little bit more today. It's very schematic, just to try to understand. So the first thing was VEGF is there, is constitutively expressed. What if we get rid of it? What's going to happen? What is the role of VEGF there? Now, I'm going to introduce you two studies. The first is from Susan Quagan, friend and competitor in Toronto, now in Chicago. She did this elegant work. She knocked out VEGF, she took it away from the podocyte in a normal animal. What happens? The animal, remember VEGF is permeability. Well, the animal becomes even more proteinuric. It leaks. The vascular wall falls into pieces. So VEGF is important. You want a clinical parallelism here. And for example, if you treat patient with VEGF inhibitor for cancer, for example, the patient will become proteinuric because the inhibitors will reach the kidney and inhibit. We've seen patients treated with VEGF inhibitors for proliferative diabetic retinopathy with the same problem. So VEGF is there and is essential, and we cannot get rid of it. So VEGF is a good guy here in normal physiology. We did similar work at the same time, but our approach was different. We overexpressed a soluble VEGF receptor. What is this? I tried to explain in simple words. We express a protein there and there where VEGF is expressed that will be secreted, and it binds to VEGF and it mops it away, preventing it to bind to its receptor and act as a cytokine, as a growth factor. What we have observed is, yes, we achieved this overexpression. We achieve an inhibition of this action, so the system was working, but we also see an upregulation of VEGF. So the system itself, and this is beautiful actually, we try to inhibit the system turns on mechanism to bring the system to a physiological sort of equilibrium, to maintain the normal function of the barrier. And indeed, when we looked at protein in the urine in this animal, there was absolutely no difference. So VEGF is there, is important. I don't want to make it disappear. And anytime I try to get rid of it, in normal physiology, remember, the system is able to do something to try to correct. These are the two concepts here. In diabetes, I just told you VEGF goes up in diabetes. It's there, it increases permeability, secondary to hyperglycemia, to hemodynamic perturbation, and etc. So here we have our podocytes, which produce a lot of VEGF. And we are in diabetes, we are in disease. We have hyperglycemia, hemodynamic perturbation, hitting the glomerulus. We overexpress this time, again, this mopping agent that takes VEGF away from its action. Indeed, we see a downregulation of the activation of the receptor. Indeed, we see an improvement of the protein, of proteinuria, or diabetes-induced proteinuria, and we see a dramatic improvement in this model, in these experiments, of the extracellular matter, of the scar that characterized this animal. So in a way, we could say, important, it works, so we might translate it to human. The step to go to to be able to translate this to human are quite long. And as you have understood, we really have a small window in which we can work. And as we know in disease, in the glomerulus, we have a scar at the beginning, a little scar, a bigger scar. And when you have a scar, you don't have cells, you don't have VGF. So really, it's going to be extremely tricky. So at the moment, I guess the VGF story for kidney disease probably holds that we need a little bit more information. Certainly, there are other directions we and others are working on. Angiopoietins. What are they? What do they do? I told you that angiopoietin 1 is a good guy, keeps your vessel intact, happy, and steady. Angiopoietin 2 inhibits the action of angiopoietin 1. Now, what happens in diabetes to angiopoietin? The message from this slide is very simple. If in physiology you have a lot of angiopoietin 1 that stabilizes your vessel and your vessel is happy and works very nicely, in diabetes or in any other disease, you have an upregulation of angiopoietin 2. You have an imbalance always in favor of angiopoietin 2, which will destabilize the vessel with the idea in mind of allowing VGF-mediated endothelial cell proliferation and new vessel formation to repair. So the first thing we did in this respect was to generate another transgenic animal, another model in which we mimic this excess of angiopoietin 2 that exists in diabetes. What will happen? Angiopoietin 2 is usually not there, or it is very, very low. So we tell the podocyte, produce a lot of this angiopoietin 2 and see what happens. What happens is that we observe an increased leakage of the glomerular filtration barrier, which is expected. This was independent of blood pressure, so really destabilization of the barrier. And when we look at the morphology of with electron microscopy, we couldn't see really much. All that we noted was apoptosis, cell death of the endothelial cells. In a way, this is physiology, this is not diabetes. That was to reinforce the idea that clearly there was an excess of angiopoietin 2 will result in a vascular leakage. Similarly, our friend and competitor Susan Quagan in Toronto, they knocked out angiopoietin 1. So again, the idea was to create this imbalance in favor of angiopoietin 2. The phenotype in the normal animal was nothing, while when the animals were induced diabetes, or having angiopoietin 1, there were more severe lesions. So the balance in favor of angiopoietin 2 was leading to a more severe lesion. And this was suggesting, in a way, the fact that if we were able to reverse this imbalance, maybe we could do something good. And this is the last bit of the story, where in diabetes, as you've seen, we have a lot of VGF, we have this excess in angiopoietin 2, and less angiopoietin 1. And what we wanted to do is to, this time, in diabetes, promote an excess of angiopoietin 1, to bring back the vessel to a physiological situation, if you want, from the imbalance that is seen in pathology. And this is as simple as well. We have in normal physiology an excess of angiopoietin 1. It's all about balance here, as life is. In disease, you have an excess of angiopoietin 2, whether the angiopoietin 1 goes down or angiopoietin 2 goes up. But the imbalance is always there, and it can be different at different stages, but it's always as an excess of angiopoietin 2. And then we have our intervention, which by modulating this imbalance, bringing it back to the physiological, if you want, phenotype. And the question was this, and we started to do some work. I'll skip this because it's too much. We were able to activate the receptor. And what we see in these animals, that the diabetes-induced proteinuria was ameliorated by this excess of angiopoietin 1. We were reintroducing a physiological milieu of this podocyte endothelial barrier, and this certainly has normalized, but certainly had an important impact. Now, the story is a little bit complicated, and I decided to summarize in about 5 years of work in a slide. Follow me. In physiology, as I told you, we have a little bit of VEGF, and we know it's very important. It's there. It keeps your cell alive. If you don't have it, it's bad. You leak. And we have angiopoietin 1 that keeps the vessel intact and happy. A touch of angiopoietin 2 possibly going around. With diabetes, you will learn that VEGF goes up. We'll learn that angiopoietin 2 will go up. The balance will be disrupted. And this will favor a destabilization of the vessel wall, increased capillary proliferation, leakage, albumin. And that's the index that we measure in our patients. That tells us that something is not going well. And interestingly, there is also a downregulation of that soluble VEGF receptor, which I mentioned to you before, that mopping agent that is going around. It's always produced physiologically in the kidney. And it's all towards an increased action of VEGF, which is trying to build new vessel to repair, and the presence of angiopoietin 2, which is there to destabilize the vessel, to allow new vessel formation and repair. When we overexpress angiopoietin 1 artificially in a diabetic animal, and we try to bring it back to physiology, we see an increase in the mopping soluble VEGF receptor, for example. And here's the interaction between these two systems. VEGF action is being shut down. Angiopoietin 1 will restabilize the vessel in some way. And the imbalance between angiopoietin 1 and angiopoietin 2 is again in favor of angiopoietin 1. Many other things do happen. For example, it's about activation of inus. If you remember at the beginning, I mentioned that nitric oxide is reduced, where we see an activation of the enzyme that produces inus, so probably, which is modulated by angiopoietin 1. And so we have really a system which is turning back and trying to reestablish a sort of normal vessel in a disease condition. So the vessels are more stable and less proliferation. And this is seen, for example, in these other slides, where we see a dramatic change. This is collaboration with my, it's like a brother, David Long at UCI, where we work together, and we are doing these journeys together, in which we see that there is a diabetic-mediated proliferation of endothelial cells, of glomerular cells, with diabetes. And that is completely shut down by bringing the balance again back in favor of angiopoietin 1 versus the prevalence of angiopoietin 2 that you see in diabetes. I guess you're going to have nightmares tonight about 1 and 2, but it's all about the balance. Surprisingly, no effect whatsoever on the matrix, on the scar, on the accumulation of extracellular matrix, on these cells coming off from the glomeruli. So, and this is what science gives us. And clearly, now more work is, why is this? What is the other bit that we are missing? Because clearly, yes, we can correct the permeability of the vessel, but of course, these glomeruli are becoming sclerotic, so they don't function. So we're going to have dialysis no matter what. So time will tell where we're going. This is one of the first data of the balance of this growth factor in patients. And this is collaboration with a good friend, Matthias Kretzler. He's from Munich, where I met him, and then he moved to Ann Arbor in Michigan. And he, with some friends, put together a collection of renal biopsies in Europe for many diseases, and not many diabetic, of course, because we don't do biopsies in diabetic. And this is RNA obtained from the glomerulus of those biopsies. So each dot is 1 or 2 glomeruli, RNA extracted, and the expression of angiopoietin is being measured. And you see, as control, we have live donor kidneys used for transplantation, and we have some patients with diabetic kidney disease. And these are patients with renal function, which is about 50%, a duration of diabetes, which is about 10 to 15 years, a reasonable control. Most of them are type 2 diabetic patients. And you see that there is the imbalance between angiopoietin 1 and 2 is shifted in favor of angiopoietin 2. Again, here, as you see, on the right of the slide. So this could represent a target for treatment. And we're trying to convince industry to jump into this because there are inhibitors of angiopoietin 2. There are antibodies that can modulate this imbalance. And of course, this will need to be tried in animals first and see, and then the big jump to human to see if I can do any better to patients. Of course, the jump is huge, but it has to be done at some stage. Sometimes something works. So the story is near to end. We have this network between podocytes and endothelial cells. We have this imbalance that probably can be corrected and targeting angiopoietins, 1, 2, VEGF, both, who knows? Time will tell. But certainly it's something that we could add possibly in the future to possibly find new target for treatment or new treatment for the patients. Now, at this point, you're probably overwhelmed attached, but I need to start telling a little bit of my story and give some thanks to whoever was responsible to having me here. I have to thank Professor Zaffaroni in Parma. I was a student with her. I was a student, so one of the many we published in the New England Journal of Medicine at the time on hyperinsulinemia and cardiovascular disease and insulin-resistant in diabetic. Then as I moved to Padua, there are 3 gentlemen there. Professor Tengens in the middle was the head of a unit at the time. I was lucky to interact a lot with Angela Vogaro and Stefano Del Prato. Which you see there is, this is not a white coat in a hospital. He's a very good chef, so he's cooking. Really very good. So if you know him, if you meet him, you should ask to go to his home, and he has to cook. It's really amazing. And they have been really instrumental in pushing the curiosity and the questions and the discussion. Really, really amazing. From there, my boss, Professor Chengo, I remember that meeting. We would like to send you to the United States to learn a little bit of molecular biology. Okay, fair enough. And when you learn something, you come back and we're going to work here with you. Very well. And so I went, and that day, went to his office and said, where do you want to go? Something nice, somewhere nice and good. And so we tried different locations on the east or west coast. We haven't tried the Midwest. And I was lucky enough that Professor Barbara Kahn in Boston accepted me. And then I moved to her, and there was a journey of about 4 years in Boston in which I learned to be a vet because I was living with animals every day of the year, every night. It was a lot of work. She's really determined lady. I guess in terms of Athena Schwann, okay. A lot of ladies here. And really, really committed, and she taught me a lot. And she was sort of also instrumental in my then future career. I went back to Italy, and I was ready to bring my expertise, what I've learned, to Italy. And unfortunately, you know how the Italian system is, not because of my professor's fault, but there wasn't really any opportunity to stay, to have a salary, to have a job, to have anything. And I remember a friend of mine who was in Boston, Dr. Doria, who's now at the Josling in Boston. He was in Boston, he came to London, job here, the job I'm in, and he said, Luigi, I really want to go back to Boston. Why don't you apply in London? You never know. And that's when I applied and was shortlisted for the interview, came here, and had the interview and was offered the job. It was a wonderful day, sunny day, in front of the Big Bang at St. Thomas. I remember I was telling to my wife, I said yes, but you know, I haven't signed anything. And we were just arrived in Italy from the US. She said, you're mad. Since then, we're here, and it's been a great journey with Giancarlo, who has been a wonderful and important teacher. We had our dispute, but out of this dispute, I've learned a lot, really. And since we end up in the cardiovascular disease a few years ago, and I think I have to also thank a lot of AJ. Thank you very much. You've been straight, fair, and supportive, and generous, I think, in some occasions. But there's always a justification for generosity, I think. And so thank you very much. And where I met many colleagues, and we are having a great time. It's hard work, but it's a great time. Now, there have been numerous people that have contributed, and I hope I put them all here. And don't be offended if you're not, but certainly PhD students and fellows. We have, as you know, an experimental sort of program which I run, and a clinical research program which was mainly run by Giancarlo when I came. Then in life I took it over, and now hopefully with Dr. Caralini we'll be able to reinforce and push that more. I really, many thanks to what Dr. Logan mentioned. We worked together at UCL a lot, we discussed. Great thanks to Cecilia, who did the last work on angiopoietin 2, great work. From the clinical research team, I think I have to do a monument to Beth. She should be here. She has kept us alive during the last year with our problems in the unit, but hopefully they will be sorted. I think a fantastic Martin Galliford, which the other day told me, I have the feeling I cannot be there to your lecture, but it's really, really nice man, and he's helping out with all the statistics in clinical trial. Thank you, Martin. Steve Thomas, when I can't find him, for all the discussions, and he's a brilliant chap. And he keeps me alive with a lot of sense of humor when we are depressed because of NHS or, sorry, the college with driver's mad, and so on. We have a lot of collaboration with Sri Lanka with a clinical trial run by Janaka and Mahem Wishura, which is completed now. It's interesting, and we might hear from it soon. A lot of collaborators out there in the UK and abroad. So really, a big, big thanks to everybody. And so now, thank you to whoever gave the money to do the job. This is a struggle. It's more and more a struggle, but at the end of the day, you end up bringing some money in and do some of the work. And last but not least is my family. This is an old picture, actually. You can see it's me and my wife with the 2 kids. My parents there, they couldn't be here. They are in Italy or somewhere else. And thank you very much to everybody for coming and for being with me tonight. Thank you.
Thank you very much indeed. I now call on Professor Shah, Head of Division, to give the vote of thanks.
Well, ladies and gentlemen, it is my pleasure to propose a vote of thanks to Professor Luigi Gnudi. Luigi, I think you will agree that we have heard a wonderful lecture, an excellent exposition of bedside to bench, bench to bedside research, addressing a very important clinical topic. And listening to the lecture, I thought that it really exemplified many of Luigi's best qualities. Careful, innovative, mechanistic research, a strong focus on important clinical questions, an eye to translation, remembering that he's a clinician even when he's in the lab, good communication in that very typical Italian style. So all in all, I think a really good example for any aspiring clinical academic in the audience. I really enjoyed it. Thank you. So can I on second year. May I invite colleagues, ladies and gentlemen, everyone, to join me in congratulating Professor Gnudi on award of the title of professor at KCL, which of course was 2 or 3 years ago, and on a wonderful lecture. Thank you.
So, ladies and gentlemen, I think we all agree that was a superb lecture. So please, will you join us all in the foyer to celebrate some more with some refreshments? So thank you very much indeed.